test. Now, I understand that you guys are placing IVs and you're answering questions from the patients, so this should help explain a lot of what you might need to tell the patients. There's 4 types of stress tests, and 3 of them require IVs. And so you guys are going to be starting a lot of IVs. The first one that you guys are involved in more, and some of you are really involved, Peggy and
Jen.
yeah, and Jen.
Karen.
And Karen,
Oh, Karen.
and do our injections for us during the actual test. And that's called a Lexi scan stress. It's an injection of regadenoson, and we do those on people that are unable to walk on the treadmill for one reason or another. Either their gait is unsteady, they have knee problems, back problems, they're elderly, or they're on beta blockers, and the doctor wants them to stay on beta blockers, and so we can't get their heart rate up with the treadmill. So we'll do it with the drug, the regadenoson. And the regadenoson, what it does is and you can ask the girls who actually do the injections, we'll often see a slight increase in the heart rate, but generally what it does is it makes the heart torque a little harder and beat a little harder, and that increases the demand for higher cardiac coronary blood flow, just like exercise would. And then we measure the amount that the coronary arteries can respond to that increased demand, which is what a stress test is all about.
How long does that last for? How long does the effects of that last
The regadenoson, when it goes in, and you can ask these guys, about 50% of the time people feel a flush, and they may get a slight headache. They'll almost certainly have the urge to take a couple deep breaths, because it's like, I think Peggy describes it as, who was in there yesterday? Oh, Cecilia. Cecilia describes it as, it makes you feel like you've climbed a flight of stairs. And so you're tricking the body into thinking that it's exercising, so you feel that flush of adrenaline that you would feel if you were exercising, and that's what they feel. So, but that's momentary, and the urge to take a couple deep breaths, of course, is momentary, and the headache goes away. Sometimes that stays a little longer, maybe for a couple minutes, but generally that stuff is out of your system by the time we have them eat crackers. We usually have them eat crackers if they don't bring a snack of their own, and drink some water, and that puts protein into the gut and draws the stuff to the gut, so that they can eliminate it faster. So that minimizes the side effects also. But like I said, 50% or more of the time, the patients don't feel really anything. We generally have them, we prefer to have them walk on the treadmill for 1 minute at 1 mile an hour on a flat treadmill. And that's more or less just to keep their legs moving and keep the blood circulating. If they can't do that, we have them sit on the side of the bed and just kick their legs, and that also keeps their blood moving. But anything to keep the blood moving and keep that, and get that stuff into the heart, make it torque harder for a couple minutes, and then shortly after the regadenoson goes in, the nuclear med tech, generally Mark, who's here most of the time, he'll inject the nuclear tracer, and that gets absorbed into the heart muscle while it's torquing, gets absorbed into the heart muscle, and then he takes the patient back when we're all done in the MOB. We'll take them back to the scanner, and they'll get re-scanned because they've been scanned at rest first before they even come over to us. They'll get re-scanned, and we'll see how uniformly that the heart muscle picked up that nuclear tracer while it was torquing from the regadenoson. And so that's the purpose of the whole thing, is to see how uniformly that nuclear tracer was infused into the blood muscle, or into the heart muscle. So, if you wanna explain.
How long does that whole process take for them? Because that's some time.
Oh,
Like,
Hours,
uh,
a couple hours, right?
Yeah, the whole process is,
once we start the IV and you take
it
them
takes a
back.
couple hours because they need to be injected with the tracer. And then, they wait a little while, then they get scanned, and then they come over to us. And generally, they've had the IV early in the morning. So you guys will be starting an IV long before they even get to us.
Okay.
And so they've got to be scanned after they've had their IV, and then they come over to us. And then sometimes they'll have to, depending on whether they walked or just kicked their legs, they'll have to wait to get back into the scanner. So the whole thing, can take
Okay.
3, I don't know what the schedule suggestion, the appointment suggestion is, but I think it's like 3 hours. And so it can be all of that.
Okay.
So they shouldn't make any other plans, but I'm sure that's a question that comes up.
Mhm.
Why does it just take 5 hours
Yeah.
or whatever? But that's the whole idea behind the regadenoson. Now, I was talking to Karen on the floor last night when I got called in. She was working, and she asked me, or we were talking about it, and she brought up a couple good points. The placement of the IVs is important, and also I know one time she prepped the patient for me, and she had him change into a gown right away before I even prepped him, and so the gowns usually go on backwards, so that they're open in the front. So if you ever do have a patient change into a gown, so you can start the IV, so they're not changing their clothes over their IV later on. If you want to change them into a gown, try to make sure that it opens in the front, and then just tape it closed or whatever to make it easy for the prep and for the.
Should we be
For the
putting them
IV.
in gowns? I don't ever put them in a gown.
Yeah, you don't have to. I
Okay.
mean, but if they have like tight
Tight,
sleeves and
yeah.
you're gonna put an IV here, yeah, it might be a good idea.
Okay.
So, and then, of course, hands and forearms are the best. The anacube, it probably isn't ideal, because they feel like they have to keep their
Sure.
arms stiff while they're walking.
Yeah.
So, that's best, and I think, probably I don't know, what would you say, Peggy, the right arm probably the easiest?
That's the way
So
they're
that you're
facing
standing
mostly,
by
yeah.
me and not having to move the bed.
But-
So, right arms are probably the best. And, yeah, that's it. And then gowns on backwards. Okay, moving on to the second type of stress test is the cardiolite stress test. It also involves nuclear medicine because it's the same type of tracer, radioactive tracer that he injects. Only it infuses into the heart with exercise, with the cardiolite. So you guys, the nurses aren't there to give the injection of regadenoson with this one. But it's the same type of thing. Mark injects the nuclear, and then they exercise for with the Lexi scan, with the regadenoson. We generally stop them, shortly after the injection's in. With the cardiolite, it's injected and they exercise for another minute, 1 more minute on the treadmill at peak exercise to let that stuff absorb into the heart muscle. And then he scans for it.
So is the cardiolite the dye?
It's
Or the stuff that
it's not a
allows-
dye, it's
But it's the
radioactive.
radioactive, okay,
You
so
can
that's why
tie it or whatever.
he's injecting that, because that's not what's causing the stress on the heart.
No,
So the patient
No.
themselves are doing the stress on the heart.
by injecting that, he kind of takes a snapshot of the heart's diffusion, the coronary arteries diffusion at peak exercise. And that's why they exercise for another minute after they warn us, oh, I gotta quit. Boom, we give the injection, they exercise for 1 more minute. And I always tell them that this is gonna be the longest minute of your life. And, because they're at peak exercise and it almost has to happen.
So have they maybe been already doing this for 10 minutes or 5
Yeah,
minutes?
yeah. So, that's another thing too. Back in the day, when doctors used to, when physicians used to attend these things, the mistaken assumption was exercise tolerance could be measured best by how far they could push a patient on the Bruce protocol. The Bruce protocol is, starts at a 10% grade and 1.7 miles an hour, and then every 3 minutes it goes up another couple degrees of incline, and 2.4 miles an hour and 3.2, and on and on and on. Rarely do we get, and it'll go up 6 stages. Rarely do we ever get that far. Stage 4 is usually about as far as we get, because at that point they're going 4.2 miles an hour up a 16% grade, which is like walking really fast up the Cooley
Sure.
Trail there, or the Cooley Road. So rarely do we get that far, but now instead of pushing people as hard as we can, they found out that a better indication of exercise tolerance is how quickly a patient gets to 85% of their maximum heart rate. So, say for instance, a person my age, 60, has 85% of my maximum heart rate is probably right around 130. So that's all the farther I'd have to go. So, and I always tell people, this might take 2 minutes, it might take 10 minutes, depending on how quickly your heart rate gets up. So, if they ask you, how long am I gonna be on a treadmill? Say it's variable for everybody, depending on your age and your exercise tolerance. I've had people within 30 seconds. In fact, I hooked up a guy that was really nervous, a young guy yesterday. Late in the afternoon, it was urgent from Dr. Stoy. Hooked him up, his resting heart rate was 120. And he only had to get to he was in his 40s, I think he had to get to 152 or whatever, and he's already in the 120s. He was nervous, and you could tell his blood pressure was up. He was red in the face, which is kind of why probably Stoy wanted him done yesterday. So, and he'd been having chest pain, exertional chest pain. So it didn't take long. I mean, within 3 minutes he was ready to quit, and he got kind of faint, or not faint, but he said he was getting weak in the legs, and that was one of his complaints to begin with. So it didn't take long, 3 minutes. Generally, a guy in his 40s, you'd expect to have him on the treadmill for, 6 to 8 minutes. Yeah, half an hour. Yeah, nobody hardly anybody gets past 10 minutes. You could probably assure your patients that they'll be done within 10 minutes, that they won't be on it 10 minutes. And a lot of them come prepared with shorts and running shoes, and I generally tell them, you're not gonna need those. You won't have to change, because you're not gonna be on it that long. And then I tell them that story about back in the day, and then now these days the protocols change, and so they're not near as strenuous as they used to be.
So Jeff, how do you figure out their 85% of their, is it based
Well,
on?
it's based on their age. It's the number 220 minus their age, and then 85% of that. So you can figure it out in your head pretty easy, but the machine actually does it for me. Once I plug in their date or their birthday, and go to the next screen, it pops up with their maximum and their sub-max.
A difference in the nuclear material that they're injecting between the
Nope,
Lexi and the
nope.
Raywa,
It's the same stuff,
Right.
same stuff. He just injects it, right after the regadenoson or at peak exercise. It's, so what that does is it takes kind of a snapshot, like I said, of the diffusion of the coronary arteries at that peak exercise. And then it gets distributed throughout the heart muscle, and then if you've ever seen a nuclear scan of a heart, the little dots appear where the stuff is, and it creates a circular pattern, and then he looks for like breaks in that circular pattern. I think that's what they look for. But
This is all checking for blockage and
Uh-huh,
if
yeah,
the blood
exactly.
vessels are old.
So if part of the heart muscle doesn't pick up, doesn't pick that stuff up, it's because there's a diffusion abnormality there at peak exercise.
Okay.
So it's kind of cool that he kind of, by injecting, he takes a snapshot of the heart right at that point, and then a half an hour later, he can scan and see what that looked like,
Sure.
you know, a half hour prior.
That's cool.
That is
So it's
amazing.
kinda cool.
Yeah.
Who comes up with this?
I know.
Let's see if this works.
And it's a very predictive test. If my part is negative and Mark's part is negative, there's a 95% predictive result that you will not have a heart attack in the next 5 years.
Really?
It's five
That's
years
reassuring.
predictive. So it's a really good test,
Wow.
and it's probably the best test, even though the stress echo is also a good test, which is what we're gonna get to next. So the stress echo, it also involves you guys because we need an IV for that one too. So 3 out of the 4 different stress tests we need IVs for. And the stress echo is just what it sounds like. It's a stress with an echo immediately after. So the patient walks on the treadmill and with the same Bruce protocol, starting out at 10% grade, 1.7 miles an hour. Every 3 minutes it gets higher and faster until we get their heart rate up to the 85%. Once they're up to the 85%, I give them the option of quitting with the stipulation that they give us 30 seconds notice before they have to quit. So they'll walk along and I'll tell them when they get to their heart rate, you can quit anytime. Most 75% of the people say, okay, I'm ready to quit, even though it looks like they could probably go further. But at that point, there's no need to go any further. The Ecotech injects, and what they inject is it's a micro-lipid bubble solution that it circulates once or twice, they watch it, when they do it at rest, you can watch like 2 or 3 heartbeats, and it swirls through the chambers, and they watch, of course, the valves flipping, and they watch the wall motion of the heart, and it just kind of lights it up a little bit so that they can see the wall motion a little bit better. So they inject, it's a kind of a white milky solution. They inject about half a syringe at peak exercise, and then the patient only goes about another 20 seconds. And the tech runs over to the other side of the table, shuts the lights off, gets set, and then as soon as I count down the last 5 seconds, that there's a big red button, stop button for the treadmill, and boom, I hit the button, and the patient, and we've practiced this prior, so that they
Runs
don't.
to the table, yeah.
You'd be surprised how many times that, they're hooked up with the wires and they've got the blood pressure cuff on, and they'll turn towards the table and then we'll say, no, you sit down on your butt, and they keep turning, and pretty soon they're laughing. So we practice the move. This is what's gonna happen when the treadmill starts.
You're gonna bust a
You're
move.
gonna hit the button, you're gonna sit down on your butt, you're gonna lie down on your back, and they all look at me like, okay. You're gonna lie down on your back, and then you're gonna roll all over onto your left side with your left arm under your head and your right arm along your hip. We call it the Titanic. That's the way she was.
Bruce.
Or the Burt Reynolds, if it's a man, we call it.
Yeah, that's good.
Now, I'm dating myself, but back in the day, Burt Reynolds was a sex
Hot guy.
And he had a poster that came out, and he's a hairy dude, but he was covered with hair, but he was naked, and I think he had a pillow or something, but he was
It was honest, yeah.
And,
We'll have to get that
We'll get that snap right out of it.
That's so funny.
So-
And how big a posters can we make?
I know, yeah.
and for the record, it was a small pill.
Oh my gosh.
So, so anyway, so that's the stress echo, but that also involves the IV, and for that one, yeah, on the right side is
Still best.
best.
Oh,
Always,
right.
I think always on the right side is probably best.
I feel like a 20th is great for that lipid solution.
No idea, but yeah,
So you have like,
If it's too small, it's too hard to do.
yeah.
I suppose, yeah, because things have to go on fairly quickly.
And why would you pick this one over others?
The stress echo, it's generally for, and I think I put that on here, it's generally for younger people, capable of walking on the treadmill for a long ways, and, well, it all depends on what they're looking for. If the person's got a murmur
Oh.
because of a valve, or
So it's maybe
maybe a
not for
structural abnormality.
Not for
that-
chest pain necessarily as much, or,
Not necessarily, the
Okay.
cardiolate's probably the
Better
best
for
for
that,
that,
okay.
yeah.
But these are all tests to avoid the cath lab, or like an angio or something.
To avoid or to,
Prior.
Move
It's
them
usually,
on.
it-
I mean,
usually,
going to the
usually,
cath lab, not
usually
cath
they'll
lab,
do
but
that
to
before.
avoid an angiogram, right?
Right.
Or plasty, and they could do all these tests and go, oh
Something
yeah, this is
emergent.
good, you don't
Yeah.
have to do this.
right,
My
right.
brother failed that and then.
Yeah,
did angiography,
because
and then went
just
cabbage.
this-
They'll do
yeah.
this, then they might do angiography if you fail this. and
Exactly,
then-
Yeah.
if this turns out positive,
Then
then
you-
So
Plan
no
B.
cardiologist should ever order these tests and an angio until you've seen these tests, right?
Right,
Mhm.
unless there's a, a really, really high suspicion, but generally that would preclude this, doing this test.
Yeah.
I mean, you don't wanna put somebody on who's having active angina.
Right.
Put them on the treadmill, exercise.
Do you know,
Well, we do get people that are, that have had chest pain the previous day or,
Yeah.
and need to get in emergently,
Yeah.
so.
Do you know what they're looking at on the echo when we get called? They don't have an IV to start with, and then they'll call us and they'll say the patient's already in and they're in the.
Yeah,
Do you know?
if they
Yeah, what
can't
is
get
that
good views because of the patient's, anatomy, chest thickness.
Oh, so
or-
it's not, it's more that they can't see.
It's more that they can't see.
Okay.
And they wanna inject the contrast so they can
Okay.
so they can see, cause they can't quite get the
Good
angle.
question.
I always
You know,
wonder if
and-
they failed something and
Yeah.
how big do I need this IV to be, that's what
Yeah.
Those, they give you 22s.
Yeah.
When they're in the room, I feel like they always hand me a 22,
Oh.
blues.
Which
Yeah.
always
So
struck
whatever
me as
they're
odd if
giving
they
in
just
there.
failed some cardiac.
Well, that
test.
lipid bubble stuff, the micro bubbles, it's a fairly, thin, yeah.
oh, is it?
Oh,
It's
maybe
not
that's what
viscous,
they're doing.
it's a pretty thin, watery
Oh, so you can
solution,
bubble it.
so it probably would go into a 22.
Oh, okay.
And I don't know how
But why are
viscous
we-
that other stuff is.
Why are we
cardio.
doing them in the room versus getting them to do it?
Because they're
they can't
usually in
see.
the room already.
Yeah,
Oh.
they were scheduled for one that didn't need an IV.
And you
Right.
guys,
Right.
oh.
Right.
And
then
then
you get
Plan
called
B,
into the room.
it becomes Plan B.
Oh, okay.
Exactly, yeah. Sometimes people are more sensitive to, sometimes they have to push pretty hard with that probe, and they're pushing in between the ribs, and
Oh.
that can be painful, and if they can't quite get the angle to get because the heart's
And we don't have any big
tilted or
people.
shifted,
Sure.
they'll call for an IV so that they can
Oh, okay.
light up the chambers and see them a little better. So
Okay.
that's why.
Hmm.
And then the last stress test is just the general treadmill stress test, in which case there's only admitting, or the girls out front, and us involved, and the patient. And so generally we don't need an IV, so you guys aren't involved in that kind of thing. And all that is I hook them up with the general hookup, and they walk on the treadmill, and I just watch the electrocardiographic data
Mhm.
on the screen and watch for signs of ischemia. And as you all know, when the heart's beating, it's caused by a nerve impulse that starts in the SA node and travels down through the nerve pathways, all at the same speed and in the same route every time. So this nerve impulse is traveling, and so as the heart demands more oxygen because of exercise, those coronary arteries have to supply it, and if they can't supply it, that part of the heart muscle becomes starved for oxygen. So that nerve impulse that travels down through the heart will either go around that part that's being starved, or will slow down as it goes through that part. And either one of those two things will change that waveform, the regular QRS waveform. It will change it in different ways depending on where the ischemia is. So that's how you can, and that test is more or less used just as a screening tool for generally young people who can walk on the treadmill, and that the doctor thinks, well, they've got a strong family history, I just want to do a screen to see, you know, how they do, or maybe they've had shortness of breath on exertion, and not necessarily chest pain or anything like that. So generally that's just and some doctors prefer those. So, but things can be missed with that one. I mean, the EKG doesn't always change dramatically, even though they might be having some ischemic problems. So it's not as predictive as those other ones. The stress echo is very good, but the cardiolite is the best. And then, of course, the regadenoson, that's a pretty good test too, but of course, then again, you're not exercising the patient, so you're not putting the heart under this strain that exercise would, so. And then, so that's it. Any,
I don't think I've seen them.
any questions? Any more questions?
But defunded
is
it, is
going to be
it?
starting some of the IVs.
Very good, thank you.
They've been doing.
Yeah,
those,
ER does quite a few of the IVs. When they first come in and they check in, they send them to the ER quite a bit. Now, I don't know if that's gonna change and it's gonna be all procedure. Well, now that you guys are there on Tuesdays now too, we might tap you guys on Tuesdays.
I think the Lexis, those are mostly started in ER, aren't they?
Right,
they
because
come
they start on
early.
the scanner.
And X-ray.
They
Right,
come early
right.
and go to X-ray,
Oh,
yeah.
okay.
I think those
Yeah,
are
that
the
makes
ones that
sense.
go X-ray, otherwise, most of them come to us, I think, if we're open.
Okay,
After
so yeah, that makes sense, because they go to the scanner first for the Lexi.
Yeah.
So where do most of the orders for these procedures come from? Is it their primary or cardiology?
Cardiology, quite a bit,
I just kind of feel like
and
maybe
primary.
the patients need a little more education. I would say 85%
Have no
of the
idea what they're
time,
doing.
they
have
come
no
back
idea what's
and,
going on.
no, they have no idea, and their question is, well, why do I need an IV? And I can answer that
Right.
question based on what you gave me, but I kind of feel like the patient should have a little more education before they come down, knowing that they're gonna have an IV and stuff. So I don't know if maybe that needs to start with
Sure, we
cardiology or
could-
their primary or something, I don't know.
Talk to them.
Well, we could maybe make something up and distribute it to the offices.
That would be
You know,
good.
if you
Yeah.
wanna, if you're gonna refer a patient to us, please notify them of this, and this.
Yeah.
Do you
This is
think
what
that the
this-
scheduler, when they talk to them about what they're scheduling them for, that they don't, I thought they had a little thing
Oh,
that they talk about it,
I
the
think,
schedule.
I think most patients are aware they're gonna have an IV when they get here.
I
Well,
wonder-
she's saying no, but I think that the front desk, when they're scheduling them, has a little blurb that they're saying, so we can just do a double check too at that point.
Well, I wonder if it needs like a mailing, like, because, you know, if all of a
Ours-
sudden, if you're in because you're having heart, or, you know, you're worried about heart things, so you're not
Thinking.
focusing, and they very well could be told every time you need an IV, or you're
And
gonna
that's
have
not
this, but they're not, you know,
Not
that's
remembering.
not what they're focusing on. I wonder if like we send a letter for a colonoscopy, you know, this is what's gonna happen and this is what we expect. I wonder if a letter with, once it's scheduled, would.
It
Yeah.
feels like there's a quick turnaround, we don't have these scheduled very
Right.
far in advance, I mean, they're like
Thank
scheduled the
you.
next day.
Yeah.
Right.
So the
Right.
timing, I think, would be harder for that piece.
The other thing is, though, I'm just thinking for more information, if a patient wanted to, is we have all those instructions online. So if you made that schedule, you could say if you want to see, you know, a written explanation and what to expect, it is online. You know, that way there wouldn't be any mailing and they could get it. If those people
That are inclined.
that want to learn more
Right,
could.
Yeah, generally, Generally, the people we're doing stress tests on are elderly
They probably don't know.
for the most part.
Don't
If
know.
they have
But-
a handout at their primary and the cardiology, if there's a handout available, they just.
Mhm.
And
Well,
so
we found
I'll-
out, we found out from prior experience that people don't always read the handouts.
No.
No.
They've already heard about a stress test that their friend had
Yep.
10 years ago,
They
and so they know exactly what's gonna happen because of what happened
That's
to
what
them.
happened to Bob, right?
And so they rarely read these, and we always suggest for the Lexi scan, we always suggest that they bring, well, I guess it's worded, bring a snack if you like. So rarely do they bring their own snack, and so we distribute the crackers. So a lot of them don't even
Don't
realize that they were supposed to bring a snack,
Yeah.
or can even remember reading that part of it, so.
And they're told no caffeine too, because they can't have caffeine.
Yep, and we'll have tests canceled all the time, because
Because they
people
wanna
that
come in and
that
drink
drink
their coffee.
Generally 2 cups in the morning.
Can any
And
of the
decaf
tests,
coffee too is a
not okay.
no-no, yeah.
so none of the ones we're starting IVs on can have caffeine?
No.
Okay.
Well,
so don't offer
what do you think about that?
Yeah, do we need to ask them before
The
you start the
Lexi-
IV?
Well, that's what I'm thinking. I think they
Why
all,
torment them with the
Yeah,
IV?
so it'd be the Lexi.
Everybody, because you don't want that, you don't want the
Heart rate to be up
heart rate to be
artificially.
up artificially, yeah.
And then I have one more question. Which one of these is the 2-day deal?
Well, if somebody's heavy enough, and I think the weight limit is like 250 or 280, something
Okay.
like that.
That would be the guy yesterday.
The dose, yep, yeah, exactly, he was a 2-day. He
Yeah.
came back for his resting scan the next day. There's a limit to how much radioactivity you can put into somebody, and so they have to split the dose, and they split it up from one day to the other. Because one dose has to go in for the resting, and then another dose for the exercise. And if you're doing them both on the same day, and the dose is too high, then it's a precaution. So anybody that's heavy enough to warrant that big a dose gets split into 2 days, and they have to come back the next day.
Kidneys.
That's a good question. I didn't even think about mentioning that.
So do you want us to ask if they've had any caffeine before you start the IV?
Yeah, that's probably a good idea, because if they've had caffeine, and their heart rate's 110 already, because they've had their 2 cups in the morning because they forgot, that's more,
Because I didn't know
that's,
that that was.
that's a reason for not doing the test and not starting the IV that day, so.
And is that for the stress echoes as well, or is it any of these? Just that they're not supposed to have caffeine?
The stress echo, yeah, the stress echo, you don't want their heart rate up artificially for the IVs,
Okay.
so.
But I don't think we're supposed to, I think we're doing the test ourselves.
So caffeine or decaffeinated coffee.
Yeah, decaffeinated coffee,
I forgot to
right.
stop mine, right?
Because apparently decaf still has.
That's a,
Debatable offers, you know.
So even-
I didn't do mine. I
Right,
forgot.
you don't want any of that kind of stuff.
Did you have stress?
Well,
Water or
yeah, I
milk,
was having arrhythmias.
only in the morning, or a little bit of juice.
They're told they can have it like
Well,
breakfast.
this is a while ago.
But
But
no
my
coffee.
heart rate, but my heart rate could go up
Right.
even on the beta blocker.
Is that it? Any other
My heart
questions?
rate was going up with everything.
The crash cart is right around the corner in a closet, just down from that single bathroom that's back there.
So you don't bring it into.
No. Rarely do we can see things based on their subjective data that they're giving us, and the objective data that I see on the screen. We can pretty much head off any problems to the point where we need a crash cart, but it's always near at hand.
This is really good, thank you.
All right,
That's good
thanks.
information.
I have one more question. How many do you think you canceled because of the caffeine thing?
Probably
That we've started-
one a month maybe.
Oh.
And we do about 40 to 50 stress tests a month.
Wow,
So we're averaging about 2 a day now,
wow.
almost.
so with,
Sometimes it's 3 and 4, so.
with the Lexi scan, I know that the doctor who ordered it has to be on call, like they're notified before it starts.
Before any of these tests, we.
So that was my
we-
question, is that the
Because they used to
same
be
with
on
the other
call.
ones? Is there a doctor on call while you're
Yep,
duties.
one of the stipulations is changing the protocol from where we were always waiting for physicians to come
Yeah,
over and
yeah.
stand next to the treadmill, decide when we're gonna stop. We were always running late, always waiting for physicians. By the time you get to the third stress test of the day, we're an hour and a half late, everybody's pissed off. So when we did away with the physician having to be there, a few physicians still came by, Adorn used to attend, Hellman. Now nobody comes, but they do have to be in-house in case we need them in an emergency. Or there's questions too, I'll hook somebody up and they'll have a blood pressure of 190 over 115. And it's like, do you really want me to start this? And generally the answer is yes. And generally, somebody that starts out that hypertensive, their blood pressure will come down once the apprehension about the test, and they get on the treadmill and they start to relax a little bit, and they realize that it's not gonna be as bad as they think it's gonna be, and their blood pressures generally come down, and as their muscles are working and their vessels dilate, the blood pressure comes down too. So it's usually just a matter. Blood pressure is so relative to the moment. I always hook people up, and that first blood pressure, they say, "Oh my God, my blood pressure's never that high," and it's like, it's all relative to the moment. Your blood pressure can go up 20% just in the act of talking and communicating, as opposed to sitting quietly. I said, in the UK, doctors can't prescribe hypertensive medicine for people without a 24-hour mobile blood pressure cuff that they wear home, and so there has to be a trend of hypertensive readings for 24 hours before they can even prescribe blood pressure meds in the UK. And so a lot of people are on blood pressure meds that really don't have to be, because they're just apprehensive at the doctor's office. And it doesn't take much apprehension to bring that blood pressure up. Now, generally, when they're exercising, you see the systolic go up and the diastolic go down. And so they kind of separate. That's the proper vascular response to stress testing, is the separation of the systolic and diastolic. And so, yeah, most people's blood pressures will even out. And I'll always joke with them when they're walking on the treadmill and their blood pressure's perfect. I'll say, see, this is all you have to do is move like a shark, like 24 hours a day. And your blood pressure will be fine. So, any other questions?
This is great.
This is
All right. Well, good, thanks.
Thank you.
Thank you.
All right. So keep these around as a cheat sheet, maybe, wherever you
Carry
start the IDs or whatever, and that